Hi, my name is Dr. Jennifer Kosek. I'm a radiologist in Santa Barbara, California, and I am here to talk to you about breast imaging. What is breast imaging? We're talking about radiology exams, which are designed to evaluate for abnormalities in the breast. These exams are interpreted by radiologists who are doctors specializing in radiology. These exams include mammography, ultrasound, MRI, and PET-CT. This includes screening exams, which are of asymptomatic patients, and diagnostic exams, which may be symptomatic patients or asymptomatic patients who have abnormalities found on screening exam. Why do we perform breast imaging? We want to find breast cancers as early as possible, before symptoms are present, which can increase survival, but also we're increasing treatment options for those breast cancer patients. We also do breast imaging in order to diagnose causes of breast-related symptoms. Sometimes this may be simple reassurance. There's normal breast tissue that is being felt. Maybe there's a benign cyst, or maybe we do find something malignant and we're going to help dictate the next step. Common benign causes of breast symptoms can include cysts, which may present as a lump, pain, or both. It may be related to benign masses, which can also cause lump, pain, or both. Sometimes symptoms are related to changes in hormone levels, which can cause pain and swelling. Sometimes this is related to pregnancy, maybe secondary to hormone replacement or menopause. Sometimes breast symptoms may be secondary to trauma. We may see a lump, swelling, or bruising. Sometimes symptoms are secondary to a change in weight. This can change the size of the breast and the tissue composition. And how does breast cancer present? Sometimes there can be a change in shape of the breast. We may see nipple discharge or nipple retraction, red flaky nipple, breast skin edema or dimpling, enlarged lymph nodes, or there may be no symptoms at all. So this is where we're really relying on breast imaging. So here are a few breast cancer statistics. Basically, I want to point out that breast cancer is very common. It's the most common after skin cancer, found in women. It's about a 1 in 8 chance of breast cancer, which calculates to a 13% lifetime risk. The average age is 62. And then here you can see some statistics from the American Cancer Society estimating how many breast cancer cases we'll see in 2023 in both women and men. Here's a slide just showing there are a number of risk factors that can contribute to breast cancer. And some of them we can't do anything about, such as age. Down at the bottom you can see there are a few listed that can be protective. So we're talking about exercise, maintaining a healthy weight, and limiting alcohol intake. This is just a different way of looking at similar information. And you can see the big number there, 75%. This is just a reminder that more than 75% of women who develop breast cancer actually have no family history of breast cancer. And then listed here, age, family history is important, how many children a woman has had, obesity, genetic mutations, history of chest radiation, and some others. And in talking about breast cancer risk, there are a couple of models that are used to calculate breast cancer risk. The two common models we talk about in radiology are the Kosek and the Gale models. And often radiology software has a risk calculator built in. So radiologists can actually help identify high-risk women. All the clinical information, including some of the questions that I just mentioned on the prior slide about family history, et cetera, actually gets plugged into the system and it'll give us a number. Women who have a lifetime risk of more than 20% are considered high risk. And in those women, we're talking about high-risk screening breast MRI in addition to mammography. This slide is just a chart that shows in high-risk women that not only are we starting screening earlier, but we're including MRI in addition to mammography. And this slide, it's a busy slide, but basically I just want to make the point that we do recommend screening starting at age 40 in an average risk woman. So this is excluding high-risk women who need to screen earlier. And there have been a number of studies done looking at what age we should start screening. The most lives saved and the most life years gained are when we're starting screening at age 40. So this is a recommended age to start screening by both the American College of Radiology as well as the Society of Breast Imaging. And again, just bringing that, making that same point, mammography screening beginning at age 40 helps reduce breast cancer deaths by 35% since 1990. Even so, 40,000 US women will die from the disease each year. If all women 40 and older would get yearly screening, breast cancer deaths would actually drop 40%. Okay, so in talking about breast cancer survival, there's a database referred to as a SEER database where we're looking at survival statistics. So this database is looking at survival rates. It's separate from what many in the medical community are familiar with called the T&M staging. And it groups patients into localized, regional, or distant disease. And this is just a chart showing that the majority of patients we're looking at have localized disease, so it's confined to the breast. And in this chart, we're looking at the 5-year survival for those patients. So you can see in patients with localized disease, there's a very high survival at 5 years, 99.3%, and you can see it drops with regional and distant disease. And just another graphic showing that 5-year survival rate of 90.8%. So this is just to make the point that breast cancer is treatable, and it's most treatable when we find it early. Okay, so then just a quick comment about T&M staging that I referred to earlier. So this is a standard that we use for classifying the malignancy of a tumor. The T refers to the size of the tumor, N refers to lymph node involvement, M refers to distant metastasis, and then we also look at hormone receptor status, HER2 status, and the grade of the cancer. And this is just a chart showing how we break down the T category. I won't read through all of it, but you can see we're breaking it down by millimeters, centimeters. We're looking at pretty small cancers in the T1 stage, and then all the way up to the T4 where it's pretty locally advanced. Okay, so this chart is showing the N category, or the lymph node involvement. We're looking at the level of lymph nodes involved, how many lymph nodes are involved, et cetera. And then this is the M category, so looking at is there any distant metastatic disease and how that's broken up. Okay, and this chart is just bringing all those categories together to show the breakdown for stage 0 through 4 based on the T and M categories. Okay, so how does breast imaging contribute to stage? We're looking at size of cancers, we're looking at assessment of chest wall, adjacent structures, lymph node involvement, other organs, and all of this is going to help with biopsy and treatment planning. So here we have an illustration that just shows what we're looking at with breast imaging. So we're looking at the breast tissue, we're looking at adjacent lymph nodes, which includes axillary, internal mammary, and supraclavicular lymph nodes. And of course, breast cancer staging also requires valuable information from pathology, which is initially evaluated with biopsy and then later with surgical pathology. Okay, so as I mentioned before, who should get breast imaging? For average risk women, we're talking about starting at age 40. We also image any patient, male or female, experiencing new and or concerning breast symptoms, and this would be a diagnostic exam. And we're talking about any patient, male or female, identified as high risk for developing breast cancer due to strong family history or a genetic mutation. For screening exams, we're talking about average risk women starting at age 40, a screening mammogram, in addition to whole breast ultrasound if there's dense breast tissue. And then in high risk women, we're talking about screening mammogram as well as breast MRI. So what is mammography? A mammogram is a type of low-dose X-ray designed to evaluate the breast tissue. And we get a lot of questions about radiation dose. So just a quick note on that. Mammogram is the lowest dose of radiation that we use for radiology exams, and we're talking about a few weeks of natural background radiation. You may have heard reference to 2D versus 3D mammography, or 3D is also called tomosynthesis. The difference there is that 2D mammograms are single images and the 3D mammograms are multiple thin slices which can be scrolled through by the radiologist. Okay, so here is an image of the left breast. It's a 2D digital mammogram, and there's a triangle that's showing the site of a palpable lump. And this image is a little bit blurry on this presentation. I apologize for that, but if you were able to scroll through the images on a radiology monitor, you could see on these 3D tomosynthesis images that there's an architectural distortion, which is an area that is disturbed by something in the upper part of the image where there's more white. And it's the same patient, but better seen with tomosynthesis. So for a screening mammogram, we're talking about finding breast cancers before the patient has symptoms. As I mentioned before, that's going to improve treatment options and improve survival. Typically, this is going to involve 2 views of each breast. So the top images are CC view or craniocaudal, and bottom images are MLO view or mediolateral oblique. Sometimes we'll need additional views if they're implants or we are having a hard time including all the tissue in those 2 standard views. Here's another example of a screening mammogram, typical. This is just to show how we talk about locations within the breast. We divide it up into anterior, middle, and posterior, and then we talk about the breast like it's a clock. So you may hear us say we're looking at something at 12 o'clock, 3 o'clock, and then we'll also give a distance to the nipple. And just a quick note on image quality and positioning. We always want to include as much breast tissue as possible so that we adequately evaluate the entire breast. We also require good compression, which holds the breast tissue in place, and then it also minimizes the amount of radiation needed. A thicker piece of tissue or denser tissue may require more radiation to penetrate that tissue so that we get a quality image. And this is going to allow us to find subtle or small findings, which is what we would really like to do. Okay, so what might we see on a mammogram? We're looking for masses, lymph nodes, calcifications. We may see vessels. Of course, we see breast tissue. We may see scar or distortion. Breast masses we characterize by shape, density, and margins. We talk about whether it's new or stable, number of masses, and masses can be benign or malignant. Here's a graphic just showing the different shapes of masses. A round mass is typically a more benign shape. Irregular is more concerning. We may talk about the density of a mass, low, equal, or high density. And we'll talk about the margin of a mass. So circumscribed, meaning it's nice and smooth, obscured, microlobulated, indistinct, and then spiculated. You can see it has jagged edges, and that's a more concerning shape. We're also looking for calcifications. And these are characterized on mammography. We talk about the shape and distribution of the calcifications. Usually we do not see calcifications on on ultrasound. We can, but we don't really characterize them very well, and they're not seen on MRI. Sometimes we may require additional imaging if the calcifications are new, changing, or if it's a baseline mammogram and we need additional information. And calcifications can be both benign and malignant. So here's a variety of different types of calcifications that are typically benign. And then here we have more concerning calcifications, and you can see in the amorphous category that can be benign or malignant. So there are definitely some areas where there's overlap on how they can look, and so we really want to do our best to characterize what needs to be biopsied and not. And this is just showing the different distributions that we talk about. In general, diffuse is a more benign distribution, and then in the bottom right you can see segmental, that's a more concerning distribution, and then groups, linear, regional, these are all descriptors that we'll use to talk about the calcifications. Okay, so in a mammogram report, the most important information is we're going to have a BI-RADS. That's a standardized terminology that is used in breast reporting that enables us to communicate the results and what should be done about the results. We're also going to talk about breast density and then describe any findings if there are any. Okay, and then this is just a chart that shows the ACR BI-RADS lexicon. So we have certain terminology that we like to use for mammography and for ultrasound. So you may see some of this terminology in your mammogram or ultrasound reports. Screening mammogram results. These reports should only be a BI-RADS 0, 1, or a 2. 1 and 2 basically come back next year. Mammogram is normal, or if there's a finding there, clearly benign findings. A BI-RADS 0 means we need more information, so either additional imaging or if there was prior imaging that isn't available for comparison. If we need additional imaging, that's what we refer to as a callback. So the patient will be notified by the radiology department to come back for that recommended additional imaging. We'll also mention the breast density, which is A through D, with A and B not being dense, and then C and D are dense breast tissue. And then this image just shows the difference between the different densities, with A being fatty or the least dense, and then D being the most dense. And then this is a nice illustration that shows what a breast tissue looks like. What breast tissue looks like on mammography and ultrasound. So in the top images, we have a very dense breast tissue. That would be a D category, or extremely dense. On mammography, you can see there's a lot of the white tissue. On ultrasound, that tissue also can look white in the center of the image. And then going to the middle row, it's a little bit less white on the mammogram and the ultrasound, and then on the bottom row, that's fatty tissue where there's just scattered white areas, scattered fibroglandular tissue, and then on the ultrasound you're going to see there's more of the dark gray, that's more fat rather than the denser tissue. And why does breast density matter? Dense breast tissue can obscure abnormalities in the breast, which decreases the sensitivity of mammography, but it's also increases the risk of breast cancer 4 to 6 times. And the biological mechanisms aren't completely understood at this point, but this may be due to increased cell turnover, more biologically active tissue. So it is a risk factor on its own. And this is just to illustrate the difference between a fatty breast and a dense breast. You can see the circle is around a cancer, and it's very easy to see that small cancer, which is a white spot in the middle of the image on the left, and then on the right, a little bit harder to see, you have that dense tissue partially obscuring it. And then this is just another example of a dense breast. The image on the left is a 2D image, and then moving to the right, that's a 3D or tomosynthesis image. A little easier to see, and I'm sorry I can't illustrate a video clip to show. Scrolling through it would be a little more obvious. And then again, moving to the right of that, we have the 2D and the 3D images in the other view, the MLO view. And this chart is just showing that dense breast tissue is very common. 40% of women in the US will have dense breast tissue. And so we're seeing a lot of dense breast tissue in breast imaging. Okay, so moving on to breast ultrasound. Ultrasound generates sound waves which can produce pictures of structures in the body, so in this case, the breast tissue. There's no radiation involved. We can use ultrasound as a screening exam or a diagnostic exam. So this is just showing an ultrasound probe at the top, and then all the structures that we'll see on an image. So we see the skin, we see the glandular tissue, fat, we'll see muscle beneath that, and then ribs, and sometimes we can see the lung underneath the ribs. So here's an actual breast ultrasound image, and if you can remember the graphic that we just showed, we see skin at the top, and then the fibroglandular tissue, muscle, and then rib is the white spot with black behind it. The rib is very dense, so it blocks all the sound waves from traveling past it, and so that's why we don't see anything behind it. So we do screening whole breast ultrasound as an adjunct to mammography and dense breast. So that's category C and D. And since it's a screening exam, we're evaluating all portions of both breasts. And then we also look at the low axilla to look for any abnormal lymph nodes. So as in the screening mammogram, this exam should be a BI-RAD 0, 1, or 2. This is an example of a normal screening breast ultrasound image. Top image is a coronal view, which is basically like you're looking at the breast. The dot in the center is at the nipple. The bottom image is a transverse view, or looking sort of through the side of the breast with the skin at the top and then the chest wall at the bottom. And this is normal. And this is a different type of screening ultrasound. So we're looking at a transverse image here, and you can see on the image there's a yellow circle that's marking a dark spot. So that was called back for further evaluation, so by BI-RAD 0. And then on the diagnostic exam, which can include looking at that area from different angles and different positioning, as well as looking at it with color images, that dark spot persists. That was a mass, and that turned out to be a cancer that was found on this screening ultrasound. Focused or targeted ultrasound, that's different from the screening exam because we're focusing on a certain area of the breast or axilla. This may be to evaluate a symptomatic area, such as a lump, or we may be looking at an area of interest seen on a mammogram, or sometimes something that was seen on MRI. And it's often performed at the same visit as the diagnostic mammogram and interpreted with the mammogram, so they're interpreted together. And here is a chart just looking at different ultrasound characteristics. I won't go through all the words here, but at the top you can see the assist. We talk about an anechoic structure, and then hypoechoic sometimes can mean a benign mass, such as a fibroadenoma. Sometimes it's a cancer, and we go into the shape, the margins, whether we see any calcifications, etc. So here are 9 examples of benign fibroadenomas. So these are all hypoechoic masses. They have variable shapes. The top left is a pretty circumscribed, benign-looking mass. If you look at the bottom left, labeled number 7, that one had some irregular margins, and so it was biopsied because of that, but found to represent a fibroadenoma. And sometimes patients may feel fibroglandular tissue. It feels like a lump. And so this is an example of that. Patient came in with a palpable lump, and on mammogram and corresponding ultrasound, there's just normal looking tissue there. Sometimes, especially in the upper outer quadrant of the breast, there can be more of the fibroglandular tissue, and it can really feel like a lump to a patient. Right. Here are 9 images of cancers. You can see how these look different. They're more irregular shaped, kind of fuzzy, indistinct margins. We talk about them being more vertical or wider, or taller than wide, and so looking from the top down, they just have a more vertical appearance. The top right image, there are little white dots inside the mass. Those are actually calcifications, which we would be able to see on mammogram and characterize as concerning looking calcifications. So these are all cancers. Looking at lymph nodes, the image on the left is a normal lymph node. So it looks sort of like a kidney shape. There's a white center, which is the hilum, where the vessels and lymphatic channels are. And then the cortex is the dark, sort of C-shaped or kidney-shaped part of the lymph node. And then the image on the right are 2 abnormal lymph nodes. You can see they're round, they're dark or hypoechoic, and we don't see the hilum anymore. So those are metastatic lymph nodes. Okay, so diagnostic mammogram. We're talking about additional views to further evaluate screening exam findings or workup of a symptomatic area. These may include magnification views, spot compression views, lateral views, and some other specific views. Here's an example of diagnostic mammogram. You can see the circle is a different shaped paddle where we're really trying to compress one area of the breast, different from imaging the entire breast. A diagnostic mammogram result can be anywhere from BI-RADS 0 to 6. So as we talked about before, 0, we need additional evaluation, which may include an MRI or may include ultrasound if ultrasound couldn't be performed that same day for whatever reason. It could be a BI-RADS 1 or 2, which are both benign. A 3 is probably benign. So usually we're going to do follow-up imaging in 6 months. And then when they come back, we'll do another 6 months. And then typically we'll do a 2-year surveillance. There's some flexibility there depending on what's going on. Sometimes we may end the surveillance early if the finding goes away or something like that. BI-RADS 4 and 5 are both suspicious and we're recommending biopsy. And BI-RADS 6 is that we know there's a cancer in that breast already. And as I mentioned before, diagnostic breast imaging often includes mammogram and ultrasound images interpreted together, and the patients will receive those results at the conclusion of their appointment. And then this slide is just a reminder that out of 100 women who get a screening mammogram, approximately 10 may be asked to return for additional imaging. And of that 10, 6 will be reassured that their mammograms are normal or benign. 2 may enter into the BI-RADS 3 category where they get a 6-month follow-up. And then 2 will be recommended to have a needle biopsy. So in a mammogram report, we always talk about why the patient's there. So indication, we'll talk about the breast composition, which is the density, A through D. We'll describe any findings. We mentioned comparisons to prior studies, and then there'll be a final assessment category, and we'll give management recommendations. And then this is just going through the BI-RADS again, 0 through 6. Okay, breast MRI. So breast MRI images are created based on magnetic properties of different tissues. We use multiple different sequences to show different information. Most of the time we want to use intravenous contrast. Breast MRI is the most sensitive in detecting breast cancer, but also increases false positives. The absence of enhancement on a breast MRI basically excludes breast cancer. The negative predictive value is more than 99%. So on MRI, we're looking for enhancing masses, non-mass enhancement, lymphadenopathy, and then in the case of breast cancer diagnosis, we look for chest wall or skin involvement. We also image a portion of the upper abdomen and the bones, and breast MRIs can have a BI-RADS 0 through 6. We occasionally do non-contrast breast MRI to look for integrity of silicone implants, but in other cases we do want to use the contrast. And then here's just a picture of an MRI scanner. When we do breast MRI, the patient is prone, meaning they're face down. And so this is what that looks like. This is an example of a non-contrast breast MRI looking at the implants, which look intact. Here we have mammogram images in the top left, just as a reminder that we always like to correlate across the breast modalities. So if a patient's had an MRI, we're looking at their mammogram, we're looking at their ultrasound, we're correlating findings across modalities. All the other images, other than the A and the B, are MRI images. So we have the bottom left is a MIP image that gives us an overall view of the breast. And then the other images are just different sequences. You can see the one letter G, there's some color on there. We do color mapping to look at enhancement kinetics. And then the bottom two images are subtraction imaging. So we give the contrast and then we actually subtract out the background tissue to make the abnormal areas of enhancement stand out more. And then this is an image of a large breast cancer. You can see there's a lot of red there. The yellow and blue are the different enhancement kinetics, with red being the most concerning type of curve. So basically, cancers like to take up the contrast and then it washes out because they're very vascular structures. Here's another example of a cancer. You can see in the left breast where the arrow is, there's a lot of color there. And then on the top image, which are the images without color, you can see it's very white in that area. So that's an enhancing cancer. These images are showing a patient who went through chemotherapy for breast cancer. So before chemotherapy, the images on the left column, you can see the white area. And then on the bottom left image, there is the red and yellow area. That was the cancer area. And then if you go over to the right column, you can see the area looks smaller on all the images, and then that color has decreased as well. So PET-CT. PET-CT is combining positron emission tomography and computed tomography. So PET is detecting radioactivity in the body. We label biological compounds with radioactivity, and then that's injected. Often this is FDG, or a glucose compound. There's uptake of the radio tracer by tumor cells, or it can be taken up by other cells that are rapidly turning over. For example, an infection may take up the radio tracer. So the nice thing about PET-CT is we're combining this physiologic information with anatomic information that we get from the CT. PET-CT is not routinely used for early diagnosis of breast cancer. And there's actually a low sensitivity in detection of small cancers due to low spatial resolution of PET-CT. So if we're talking about a 5 millimeter and 8 millimeter cancer, we may find that on mammography, ultrasound, MRI, but we may not actually see that on PET-CT. So PET-CT is performed in patients with more advanced disease, or when conventional staging studies are non-diagnostic or suspicious and we need more evaluation. PET-CT is useful in detecting extraaxillary, nodal, and distant metastases. So here's a case of a patient with breast cancer who has metastatic disease to the bones, the lungs, mediastinum, and axillary lymph nodes. So the image on the left is a MIP image that's showing the whole body. The center column is an axial image, or like you're looking at the patient's on their back and they're looking at their feet. So the top image is up in the chest where the breast and axillary lymph nodes are. The middle image is through the liver. You can see a round spot that's in the liver. And then the bottom image is the pelvis where there's a bone lesion. There are organs that actually can take up this material and excrete it. So you can see the kidneys and the bladder have activity in them, and the spleen as well, and that's pretty typical. Here we have on the left side a MIP image of the entire body. The second column are CT images. So that's B1, C1, B2, C2, those are the PET images. And then the B3, C3, that is the PET overlaid with the CT. So we're looking at the PET activity on top of the CT. So that's the difference between all those images. Okay, so once biopsy has been recommended based on our breast imaging, now what? Usually we'll schedule the procedure in the radiology department, sometimes before you've left your diagnostic appointment, depending on the facility and depending on ability to get an order for that procedure. A recommendation will be made for the preferred modality that we want to use to do the biopsy. So ultrasound, mammography, or MRI are all options. And then the referring provider will be notified of the recommendation. So types of breast biopsies, there are surgical biopsies, which are performed by a surgeon, and then imaging-guided biopsies, which are performed by radiologists. These can be performed using mammographic guidance, which includes stereotactic or 2D imaging, or tomosynthesis-guided or 3D, as well as ultrasound or MRI-guided. And this is just a picture of a stereotactic biopsy unit. So it's a needle biopsy. We just use a local anesthetic to numb up the breast. The breast is in compression, like a mammogram. We have upright and prone machines. And then this is often used to biopsy calcifications, but we can also biopsy distortions, asymmetries, or masses that are not seen on ultrasound. Usually we obtain multiple cores, and this unit has a vacuum assistance. And after we've taken the samples, we actually X-ray the specimen to verify that we have the calcifications that we're targeting. We may not do a specimen radiograph if it's a biopsy done for something other than calcifications. And at the conclusion of the biopsy, we'll place a marker at the site of biopsy. And this is just an illustration of a prone stereotactic biopsy table. These are images from an actual stereotactic biopsy. The actual target, which are clustered calcifications, doesn't project very well on these images, but at the very tip of the needle, there are very fine calcifications that were biopsied there. And again, I apologize for the quality of these images. It's not coming across very well, but this is an example of a specimen radiograph on the left and then just zoomed in on the right. But there are just some tiny calcifications, which are the little white spots in the center of the specimen. And then this is just a post-biopsy mammogram, which we always do to look at the location of the marker, and we may comment on whether there are remaining calcifications. So this is an example of an ultrasound biopsy device. There are a number of them. This is one. For ultrasound-guided biopsy, we're using the ultrasound machine to guide us. Usually the patient will be in a supine position, so they're on their back, usually with their arm extended over their head. Again, we're using a local anesthetic to numb up the area. And this is often used to biopsy masses, suspicious lymph nodes, but also distortion, shadowing, or other significant findings. And we can obtain one or more samples depending on what's needed by the radiologist to get an adequate sample, and then again, a biopsy marker is placed at the end of the procedure. Here's an illustration of what the positioning would look like for an ultrasound biopsy. And here's an example of an actual biopsy case. The image on the left that shows a mass, which is the dark circle in the center of the image, and then on the right of the image, there's that white line, which is the biopsy needle in a pre-fire position, so just pointed at the mass. And then the image on the right is, there are two arrows pointing to the mass, and then there's a white line inside of the mass, which is the biopsy marker. MRI-guided biopsies. So here we're using MRI for guidance. The patient's going to be in the prone position, so they're face down. The breast will be in compression. We'll use a local anesthetic. And the MRI-guided biopsies are utilized when findings are only seen by MRI, so we can't see it on ultrasound or mammography. And in this case, multiple cores will be obtained with vacuum assistance, similar to the stereotactic unit. Image-guided localization. So this is a procedure performed by a radiologist which assists surgeons in optimizing surgical resection of abnormal breast tissue or a lymph node. Again, we're using a local anesthetic, and we can use mammographic ultrasound or MRI guidance. There are wire localizations and non-wire localizations. Wire localizations need to be placed on the day of surgery. There's a wire that's inserted through a needle. The needle is removed, and the wire actually, a portion of the wire remains outside of the breast and guides the surgeon to the target area. And a non-wire localization, which includes radar reflectors, radioactive and magnetic seeds, radiofrequency identification tags. This can be placed days or even weeks ahead of the surgery, and the localized, the reflector or other tag is detected intraoperatively using a special probe that's outside of the breast. So here's an illustration of a wire localization, which, as I mentioned before, involves a thin flexible wire that is placed through a needle. There's a hook at the end of the wire that keeps the wire in place, and this is going to allow the surgeon to precisely localize the area to be removed, which hopefully can minimize the amount of tissue that has to be removed, but also adequately excise what needs to be excised. And here are two mammogram images showing a wire localization. So you can see the circle is the area we're after. It's very hard to see the biopsy marker there. You can see the little hook at the end. We usually try to have the hook just beyond the target, so that we're across the area to be removed. And here's a specimen radiograph, which is always obtained following the removal of the tissue. And this is just showing that the mass has been removed, the biopsy marker has been removed, and then the hook wire is also in the tissue. So non-wire localization, there are a variety of options here. And then here's a graphic of a radar reflector, just showing how small it is. These are two mammogram images. The first image on the left, you see a needle entering the breast. That's the needle that this reflector is actually deployed through. The needle allows you to get into the breast where you need to be. The reflector is deployed and the needle is removed. So the image on the right shows the reflector inside the breast at the site of calcifications and a biopsy marker. Here are two more mammogram images just showing a reflector within the breast. The left image, you can see it centrally within the breast. And then on the image on the right, it's lower in the breast. Here are several images showing an ultrasound-guided reflector placement. So the top two images are ultrasound images showing a mass, and then the reflector, which is the white line through the mass. And then the middle images are the post-procedure mammogram showing the reflector at the site of the mass and the biopsy marker. And then the bottom image is the specimen radiograph that was performed after the surgery. And then I just have a magnified version of that same specimen radiograph on the left there. Thank you for listening. My name is Dr. Jennifer Kosek, radiologist in Santa Barbara, California. I hope you have a great pink week.